This is, it's going to be well worth the wait for those of you who are hanging around and steadfast supporters of the event. I'm delighted to introduce my colleague, O'Neill Britton, who is our Chief Health Information Officer at Partners, which is a nice title. What he does on a daily basis, though, is he oversees our eCare implementation, which is about the best and most powerful way we can use Epic to transform care in our delivery system. It's one record, one patient, one record, one system. You get the idea. And for a system that's as different as our different organizations are, from community hospitals to academic centers, this is an interesting and fun time, and it's a challenge. The thing that's really amazing to me about O'Neill is he's always upbeat. He always has a smile on his face. He never has a bead of sweat on his brow. And I know that this is an incredibly stressful, big, visible project. So I'm really excited to hear what he has to tell us today. He's going to talk about beyond the blunt instrument, creating a true picture of the patient. Please welcome warmly O'Neill Britton.
Thank you. So I always, I have to start out with a joke. I start out every talk with a joke. So I always wondered what happened to the people who sat in front of the class and who always came to every lecture, and I see them in front of me now. Because if you were like me in college, you'd be long gone, and it's Friday afternoon, so thank you for sticking around. So what I hope to do today is just to talk about our Epic implementation. You know, I'll start off first with sort of the cultural change that needs to happen in order to do what we're trying to do. And then I will go into a little bit around some of the connectedness that we're trying to invoke as part of the implementation. And then finally, at the back end of the talk, I'll speculate a little bit about where we could go and some other things that are exciting that you see outside in the hallways and what that means and how do we pull all that information together. So, so here's where we started. And this is Partners Healthcare. This is an Excel file that looks at all our hospitals across the top of the row and the different systems, the mainframe systems that they run on. And so these every color represents a different system, right? And so we're trying to pull across about, you know, somewhere 12 to 19 different institutions, and each pretty much on a different system, and what that means for us. And so, you know, this is what Epic will do for us. So Epic is red, and it has taken over what we call the main backbone of how our EHR works. And across our institutions, most things will be Epic. You still see some white, right? It's impossible to do everything, but most things will be Epic. So what are we trying to do with Epic? We're really trying to create a single record, right? A single patient record. The implementation, the way we describe it, is that it's a single instance implementation of Epic, which means that there's a cultural transformation that needs to occur, because the record is no longer my record and your record. It's just one record. And so if you are in the record, for instance, in the patient's record, and the patient is at the Newton Wellesley Hospital and they're having a heart attack in the emergency room and say, we need to get this patient to cardiac surgery, and you send them to the Massachusetts General Hospital, if the Newton Wellesley people haven't closed the record, the MGH folks can't open the record, right? And so people became very surprised when we discovered this and say, what do you mean I have to finish all my work? You have to finish your work so we can start new work, right? So it's a single instance installation, and that in itself is a cultural connectedness that we never had before, because we could fragment things, you know, and the surgeon didn't have to dictate necessarily till he went home or she went home. The ED person, they could do their work over here because it wasn't connected to inpatient. The inpatient wasn't connected to the rehab hospital. The rehab didn't really know what the visiting nurse was doing. It's all connected, right? And so that has been a big cultural migration. So right now we're shooting for these 4 principles: one patient, one record, one team, and one statement, or one bill, right? But that's what we're doing. So we're connected as we had never been before, and here's sort of some examples of this. Literally, we are now able, and these are like 4 vignettes, we're now able to literally communicate synchronously across our entire health system, and that's the aim. We are not live everywhere yet. We're live at the Brigham, the Faulkner, we're live at the Dana-Farber Cancer Institute, we're live on the revenue side, on the Mass General and Newton Wellesley, and in about 6 months, we'll be live on about 85% of our system. So we're moving fast. We're live at about 40% on the clinical side and about 85% on the revenue side, but in 6 months, it will be about 85. And that will be a new change, especially when our 2 largest academic medical centers are on the same system and moving through the processes. So literally, if you're at one of our affiliated practices as a primary care doc and you're trying to get in touch with somebody at McLean Hospital because you have a patient who's in front of you or you're worried about, that communication can happen synchronously, right? If you're at Newton Wellesley and you want to get in touch with the visiting nurse, that can also occur synchronously. And we've become digital. So no more necessary, I gotta page you, I gotta call you, I gotta email you offline and try to get in contact with you. We have become digitized in many ways, and that's also a new thing for us. So, like in everything we do, not everything is Epic, and this slide is to remind me that Epic does about 75% of our business, so to speak. And when I say 75% of our business, I'm talking about most of the large footprint, because you have departmental systems, and you have, even in departmental systems, you have databases. They're not necessarily counted here, but the largest footprints are counted here. So Epic does about 75% of what we need, and we co-developed with Epic in this space, what we call Partners eCare and Epic, where we improved their emergency department module. We helped them improve their oncology module, and gave them some of the ideas we had when we had our own self-developed software. And so we shared that openly with them in the hopes that everything would sort of raise the standards, so to speak, and they have helped us in these spaces. We continue to have significant footprint outside of Epic, which includes the lab systems. But we are also working to make sure we're on the same lab system, and we're using Sunquest as our main vendor for that. So we're also working hard to connect ourselves internally. We have rewired our hospitals that allows us to connect devices. We're not connected 100% across the entire hospital, but we're connected in all what we call heavy use or critical care areas. And so we're connected literally in spaces that involve the NICU, labor and delivery, all procedural areas, the ORs, the ICUs, the emergency departments. They all now have device connectivity that allows data to flow seamlessly into the record and simply needs a validation from the nurse or a doc to say this data is good, and it flows in. And so we have worked very hard. Some of the vendors involved in this space are here. I've spoken to quite a few of them, but through interfaces and mostly through our connections with our bedside vendors, GE, Philips, et cetera, we have been able to improve the lives of our nurses and docs because the data now is sort of available and real no matter where you are in the hospital. So we're trying to connect ourselves with everyone else, and we do this mainly through the Epic Care Everywhere platform. And as I said before, only 40% of our system is currently live on the clinical side, but since June 1st, we have sent over 164,000 documents across non-partners healthcare systems. And so that's quite an eye-catching number, something that probably happened in the background, but not to this level because it required paperwork, and I usually write consent and faxing back and forth. And by being digital, we have been able to do this. And more interestingly, we have connected across all 48 continental states. And that's sort of something that we couldn't really keep track of in the past very easily. We are connected to small providers through the Epicure Link module. And so this is a sort of an important platform for privately owned primary care practices, other private practices. And you see that so far since June, we have had 613,000 look into our hospitals. And our hospitals in the past used to have the reputation of being amazing places for patients, but black boxes for people who are outside the system, right? They go, what happened to my patient in the ICU? And we'd basically go, they're okay, but you don't need to know the details. But now you can see the details, and you could see a lot of what's going on in the hospital space. And that's important for people who want to sort of understand and also get information so that they can continue their part of the care. We're trying to connect to our patients. We have about 3.5 million patients that are what we consider active across our health system. Right now, this number, active users of our patient portal, it was 500,000 in January, and now it's actually 600,000. We grew by about 100,000. And we continue to push this because we think this is we see this as part of our key strategy to sort of connect with patients, allow them certain freedoms, get them engaged. We continue to sort of work with our patient engagement committees, which involves patients too, and make sure that we're capturing their needs and making sure that they feel like they have some say into how their healthcare is delivered to them. This is another part of a key part of our mission, which is to connect our patients to research. We are probably arguably one of the largest national research funded hospital system in the country. And as you can see here, one of the things that we had not done really well, but now we could do, is to connect clinical care directly with research, and especially around patient recruitment. And here you see a best practice alert firing, telling someone using the algorithm in the background that this patient, because of the problem list that you have, matches this research criteria. And if the patient is interested, you may want to encourage them to enroll in this study. And patients, this has been interesting because one of our colleagues down at Yale have used this to really do an outstanding job trying to recruit people into clinical trials. And as many of you are aware, recruiting patients into the clinical trials is one of the hardest things to do, right? Recruitment and maintenance of participation in clinical trials. We're now connected to the Partners Biobank. And the Partners Biobank is this really cool initiative where they have been through capturing patients' blood samples, anatomic path in some cases, and consented them to allow those samples to be used in research. Most of them are just cryopreserved because the research is not here yet, but we're actively working through and allowing study data available for our researchers. We're asking interesting questions. And so patients will receive an email asking if they want to participate in the biobank. Some patients find the biobank because they've been diagnosed with something that doesn't readily have good treatments around, and they're interested to see what's out there. But some patients also want to be controls, and they actively volunteer to be part of the control process. But we email a lot of patients. So far, we have recruited about 6,000 patients that we have consented electronically since we went live. But as part of our academic mission and sort of looking at the research angle, we have worked very hard in making sure that these two things are connected. And then the biobank leads to all the genomic work that we're doing and the genomic database and all the studies that are yet to come. And there's really interesting, fascinating work that we hope to leverage using both the EHR and the biobank and all the genomic databases that we're building. So all of what I've just described is a very meaningful start from where we were. But when you consider this, that the data in our EHR at best is still quite blunt. We have static data. I talked about device integration, for instance. You can get static blood pressure measurements. You can get static heart rate measurements, but it's very hard to store waveform data. It's very hard to store continuous data, right? And so at best, we don't really get a whole picture. We get snippets, but we sort of get stills, but we need video. And we need video with audio, and we don't really get that. I remind myself that by estimates, no one really knows this answer, but 35 trillion is the number of cells by estimate in the human body. And each of them is telling us something, right? But we still are very much at the macro level and haven't really gotten to the cellular level. There are lots of people doing interesting things now, but this is one of the areas that I'm sure in the next 10, 15 years, there'll be a lot of activity as we try to get down to the micro level. Our patients are virtually infinite data repository, but with all the noise, Rahm Emanuel was right. There's a lot of, Zeke Emanuel, I keep calling him Rahm like his brother. I'm sure he loves that. Well, Zeke Emanuel is right. There's a lot of data out there. How do we make it useful and meaningful, right? Because the way healthcare works is that we tend to invest in things that will see returns in the next 5 years. It's very hard to stay at it and go at it and have the long-term vision to get to where we need. So what's common today? If you are like me and you're in charge of an EHR system, most EHRs, basic function, we have clinical and patient data covered, right? Most EHRs, we connect with home monitoring system. You have the home blood pressure cup, you can upload that. Most of them, maybe will connect to some consumer health wearables. You have Fitbit, you could download that data into the EHR. And that's sort of where most people are today. If you're leading edge, then you're into the population health space, and the previous panel, you're doing telehealth, video visits. You're doing asynchronous and synchronous e-visits. You're doing all sorts of things that are considered sort of, at the edge. You're doing probably patient-reported outcomes, where you have patients filling out surveys and you're comparing that data versus usual care. And so you have some things that may be interesting. Maybe you've created a couple of registries. Maybe you've created a registry around obesity and diabetes, and you're doing some data analytics around that and trying to get some insights, but you haven't gotten to the mature analytics one needs to have actions. You're sort of still in that space. And then you have some advanced integration capabilities, and very few folks have this around the country, but we see it in spots like what Mayo is doing with IBM around the cancer registry that you're trying to create, perhaps what BI Deaconess is doing, looking at your ICU care and looking at your payroll system and seeing experience in nurses, critical care patients, and then trying to match up sort of what staffing should be around in a dynamic way and say what's appropriate for a patient given their level of criticality. And then if you're really smart, you have connected with Blue Cross Foundation and you said, hey, what's going on? What are you learning about, all the different dynamic studies that you're doing around markers of health, and so what are we doing in that space? And can I compare it to my population health stuff and see things? And then I saw recently, I went to a talk and somebody did some data visualization on some of the population health stuff, and it looked really cool, right? But that's where we are if you're on the cool side. And I would say that probably very mature health systems can do that. We are one of them somewhat. We're probably 2.5, maybe 2.75, but that's where we are. But where should we be going? So tomorrow, I see us getting more micro. I see us going after genomics, proteomics. We're trying to get deeper and understand deeper layers, And so one of the things that will happen here now is that we'll have a tremendous amount of specimens and data. But what does it mean? How do we make sense of it? And how can we validate what we're measuring is exactly what's going on? How do we connect genotype with phenotype and say, hey, when you see this, here's the outcome. Here's the likely outcome, right? So we're going to have issues, I think, with managing volume, because as you're seeing the wearables and the meditation device and the biometric feedback, how do we bring that all together, right? And then you have the holy grail of how do you keep it secure, because the hackers are out there. And the hackers are interested in all sorts of things. They're interested in government officials, celebrities, regular folks. They're everywhere. So how do you manage privacy and security and make sure people feel comfortable that indeed what you're measuring is indeed will be kept safe and be put to good use? And then I think an earlier point raised was, we're doing a lot of active measurement today, but for things to really stick, I think we'll have to get into the space of passive measurement. And some companies are doing that. There are companies out there who are looking at spoons that measures tremors in Parkinson's patients and say, hey, what's your tremor speed? And when does it pick up when the medication is wearing off? And how do we counteract that? And if you're really smart, you could have a mechanical spoon that actually counteracts that tremor and makes the spoon a little bit smoother to your mouth, so you could feed yourself, right? Some companies are looking at devices as biometric devices that are active. So if you have a walking cane, it's measuring how much pressure you're putting on the cane and saying, what is your gait strength in real life, right? And when do you need supplement? When do you need to go from a single-foot cane to a 3-foot cane to a walker? And then how can we counteract that with PT to make sure you don't progress and have a progressive declination in your health status? So we have to combine the elements. Human beings generally advance when we network and we combine. We combine things. Even the Great Silk Road, it's sort of like First, it was traveled with donkeys. First, it was man just walking. Then he had donkeys and then camels. And then somebody invented the wheel and you could put a cart. That was a big deal, right? And so how do we combine? And the network, the exponential growth potentially of using this data, it can be realized if we are able to combine these elements, behavioral economics, our behavior and the choices we make combined with the EHR, combined with molecular measurement. And then you have all these other things that get thrown in. So you have sort of, census data and neighborhood data, custom apps, like some of the things that people are offering outside. How does that get integrated into what we're doing? Clinical devices, active devices that are passive in the background. So measuring things without interrupting the patient and interrupting the workflow of the patient as they go through their day. So I am a sort of a little bit of a poor man's historian, and I like to think of things along the times of history. And I said, where are we now? And so this is my very high level summary of history. And sort of, I think we're about here. We've gotten to the wheel, but we haven't gotten to the steam engine yet. We're about there, but we are going to grow once we're able to assimilate this data and coordinate in a way that's very helpful to all of us. So this is bigger than big data. This is huge data. We have trouble storing things today, and so now we need more storage, and this is huge data. And not only is it huge data, the data has to be put to good use. Because if it's not put to good use, you're collecting a lot of things that are exploitable. And so the data has to be put. So we'll need chief data, we'll need all these PhDs around data science and data analytics and trying to figure out what should we be using. And we have to prove a reasonable ROI for others to want to invest in it. Right? As a mature organization, we have to get beyond the 0.5% ROI that we usually see when we do these investments. So we have to move beyond the blunt instrument. And if we're lucky, we'll turn the patient into it. No. The patient should not be a data matrix. But the patient can be seen as somebody, as a composite of data. But the other thing that I will tell you from a physician standpoint, I am a practicing physician, that physicians are being overwhelmed with data. What does this mean? Why are you bugging me with this stuff? And so one of the great challenges that we'll have is how do we present meaningful data to the point of care that then is not so interruptive that the data is shunned. And I think we have a lot of work to do in that space. So, I wanted to express my thanks being here. That is my talk. I see the timer is up, and I think I have 5 minutes for questions, but thank you on behalf of Partners Healthcare, and I would be more than happy to answer any questions that anyone would have around this topic. I think I was supposed to stand on this red circle. I can't see because the light is blinding, but I can hear. Well, thank you very much, folks.